Hi, I'm Matt Smuck. I'm the Chief of PM&R at Stanford University.
And I'm Joshua Heller. I'm an assistant professor of neurosurgery at Jefferson University in Philadelphia. Today we're going to talk about patient selection for sacroiliac dysfunction, particularly looking for patients who may benefit from additional therapies, including minimally invasive sacroiliac fusion. So I've incorporated looking for patients with sacroiliac dysfunction into my practice. This started out as patients coming to me for evaluation of back pain, leg pain that's been going on for years, but not being satisfied with a lot of the treatment options that they've had offered to them and diagnoses that they've been proposed with before, and not really understanding what's been going on.
Yeah, I see sacroiliac joint pain fairly frequently in my practice. It's been a part of my practice since the beginning.
Sure.
The prevalence of SI joint pain has been pretty well demonstrated through several prevalence-based studies, and I would say the findings from those are consistent with what I see in a general back pain population. In my practice, I find it's most sacroiliac joint pain is managed fairly conservatively, just like most other spine disorders. And so I'm curious to hear from you how patients who are surgical candidates are identified in your practice setting.
Sure. And so what I've noticed with this, there's two types of patients that I see that are coming for potentially evaluations of sacroiliac procedures. One is the patient that had back and hip and thigh pain, and it wasn't recognized, and this is something that I picked up just as incorporating the physical exam and asking the right questions for them, versus those that I've had relationships with physiatrists and pain management doctors that have actually looked for these patients, and they're coming to me with the agenda of knowing about sacroiliac dysfunction and surgical treatments for it. So they're two very different set of population of patients. What I've done on most of my new patient encounters for patients that I suspect, they're giving me the story. They tell me that they may have had a remote accident, they might have had a car accident, it may be somebody who had given birth and then has had back, hip, and thigh pain. They typically sit a certain way. I don't know if you noticed this, but they sit a certain way in the office. Even when they're just coming in the exam room, you see that they're sitting a certain way, trying to relieve that pressure to not aggravate their sacroiliac dysfunction. And so as part of my whole entire workup, and I make sure that, hey, I'm not just identifying you as a sacroiliac dysfunction patient, this is just my general workup of back pain, leg pain, and maybe SI dysfunction, that I incorporate doing provocative testing as part of my exam of most of my patients. I've made it in such a way that I not only look at how they are from a neurologic standpoint, but I'm also looking to see, okay, are they doing the right things, and then on exam, are they finding the right findings to show that maybe this person is someone who has sacroiliac dysfunction. For me, I will ask them to say, hey, point to where that pain really is. And so Ford finger is a great assessment to kind of identify patients that have pain directly, at or about the PSIS. They're pointing a little bit lower than you would for a normal facet type of pain at L5S1. On my typical exam, I'll incorporate not only looking for radicular signs, so doing a straight leg raise, so once I have the patient laying on the table, but then also do a hip exam and then do the provocative testing.
Yeah, I like the hip exam part of things, because that's one place that often gets confused for SI pain.
Correct.
Normally we think of anterior pelvic pain with hip pain, but a large portion of those patients will have posterior pain as well.
Yeah.
And I find in interventional treatment of SI joint pain, frequently we'll treat it therapeutically with steroids in the beginning, and the indications for doing SI steroid injection, roughly speaking, are that the person has persisting pain that's not responsive to other more conservative treatments, and has probably 3 out of 5 positive provocation tests on exam. Absence of provocation tests actually essentially eliminates the possibility of the SI joint. But in the interventional community, there's disagreement about exactly how and where to give the injection. Do we do the injection intra-articular? Do we do it predominantly extra-articular, focusing more on the ligaments, or do we do a combination of the two? And even in the same institution, two different people might practice in different ways. And it would be nice if we had a better diagnostic approach toward the SI joint.
Sure. So for me, the provocative testing is really kind of the most important thing that I can do on my initial encounter with a patient to understand them best. And so just for the audience out there, provocative testing, if you're not familiar, involves doing several maneuvers on the patient's pelvis, and you should really become good and comfortable with doing these maneuvers, such as creating distraction across the joint, creating compression across the joint, creating a shear force by doing the thigh thrust maneuver, and doing a Faber to see if they really have at least 3 out of what we call the 5 provocative testing, at least positive, for identifying those patients that should then go off and get intervention to understand whether or not they really are a sacroiliac dysfunction patient. And so that's where NASA's statement is out there. If they have 3 out of the 5 positive, then we can send them for a diagnostic injection and to see how much pain relief that they have with that diagnostic injection. If we're deciding for surgical purposes, we want a diagnostic intra-articular injection. What I ask of my pain doctors is to send me a picture of the injection, so I know that it was a good injection. The needle's in the right spot. I see some dye going into the joint, so I can understand it. And then I also ask that they keep a pain log, so that they document what their pain score was ahead of time of the injection, and then every hour or 2 hours after the injection for at least 24 hours to see how much pain relief they have. As far as surgical selection for these patients, they need to have had at least a 75% reduction in their pain with a good intra-articular injection. And then there's some dispute out there in the literature about whether or not you should repeat that injection versus saying that is reasonable enough if the patient has failed all the non-operative strategies, and non-operative strategies being a therapeutic injection, physical therapy, medications such as anti-inflammatories, physiotherapy, and they should have actually had at least 6 months of non-operative treatment with provocative testing positive, diagnostic injections positive, and preferably 2 diagnostic injections being positive before you can offer them a sacroiliac fusion.
Right.
But the whole key to the success of doing a minimally invasive sacroiliac fusion is really making sure that the patient selection is entirely crisp. I've talked to many colleagues that have tried doing MIS-SI fusions maybe once, maybe twice, and they are not prepared because they think they have the right patient, but they didn't necessarily have the right patient for it. And then the expectations are not there. And I tell all my patients the first time I meet them, when I think about it as, hey, this may be a SI fusion patient, that this procedure is a pain in the butt. Literally, because I want to set expectations for my patients, and the procedure involves dilating through the muscle of the gluteus, and it's dilating some decent-sized holes in order to achieve placement of grafts, to achieve fusion. And it's a pain in the butt, literally, at the time of surgery because of what we're doing to the soft tissue. And then it's a pain in the butt figuratively because in order for them to heal this, they have to maintain a partial weight-bearing status for 3 weeks after the procedure. So for patients that have finally gotten to this stage and understanding that they may benefit from a sacroiliac fusion, that their expectations are set. Their pain is going to be very different. So it's no longer that sacroiliac pain, the pain that's going groin, thigh, and back. Now it's really more localized to buttock, and that pain is temporary. And I try and alleviate that by giving long-acting anesthetic to the muscle and making sure that the appropriate pain control afterwards.
And I think an important thing I heard you say is that it's just as important to identify the people who are not good candidates as it is to identify the ones who are. And for that purpose, the 2-block technique has some face validity based on what we know from other diagnostic injection procedures, where a single injection can have a high enough false positive rate that it renders the outcomes relatively poor when it's used broad scale. And when you use a 2-block technique, you improve your specificity, but you do that at the cost of a little bit of sensitivity.
I agree. And one thing that I like to try and do with our patients is that if I'm sending them for an injection, I don't, if it's somebody I identified and they weren't coming to me for sacroiliac fusion, I don't actually mention sacroiliac fusion to them at all. I tell them I'm going to send them to my colleague who's going to provide an injection that's going to help make a diagnosis. And I don't say what I'm looking for as far as whether or not you're going to be a surgical candidate or not. I'm not telling them what the percentage of reduction in their pain needs to be in order to be a surgical candidate, because I really want them going into being unbiased. Yeah. And that said, if they get an injection and there's some doubt as to the quality of that injection, then there are other ways to doing it. You can have them get a CT-guided injection too, which I often might do as my confirmatory second diagnostic injection to say, okay, we did it a slightly different way. We know it was entirely inside the joint and that it provided relief.
Great.